Do we want to do spleen or liver first? Spleen or liver first? Don't care.
Liver.
Liver.
Liver. All right. Excellent. It's much harder than the spleen. All right. Can everyone see my screen now?
Yeah.
Yes.
Yep.
Great. Hi, Jeff.
Good morning.
Okay. So obviously we're not going to be able to do ultrasound rounds the same way we do radiology rounds, because we're obviously just looking at a still image, and looking at other people's still images of ultrasounds are just impossible to interpret. And even my own, sometimes I like find a lymph node and I freeze it and I look away and then I look back and now I can't find it again on the still image. You lose the context, it's not moving. So please, like, I want feedback on this. Please let me know if it's not working for you or if you just can't see anything in it. But what I want to sort of get out of it is for everybody to just have a way of looking at things, so you've always got something to say about that. You can always get something out of an ultrasound image, because there's so many different factors which will make images poor quality, even live, even when you're doing it yourself and the probe's moving around and you've got control of it. So at least we can sort of get the gettable information out of it. So the things that I would like you guys to be thinking about anytime you're trying to look at an organ on ultrasound are the landmarks around that organ. So is it in the appropriate place? The anatomy of the organ. So have I looked at the whole thing? The size of the organ, echogenicity, and the echo texture. And I put a picture of the book here that I use all the time, which is just so helpful for ultrasounds. Anybody interested in doing ultrasound, I would highly recommend this book. It's got these tables of differentials, like hyperechoic spleen, these are the possibilities. Hypoechoic splenic nodule, these are the possible differentials. So it really helps with writing reports and things like that to have that reference. All right, so if we're starting to talk about the liver, what are the landmarks of the liver? What does it border on the left-hand side of the body?
Diaphragm.
Diaphragm, yep. Or cranially, diaphragm, yep.
Sorry, cranially, yeah. I meant more on the probe, when you're looking for the probe.
Is there a hernia on the right, Josh? Or good, so diaphragm.
Stomach.
Stomach, excellent. What else?
Spleen.
Excellent, good. So sometimes we can see them together and that's really nice because then we can compare echogenicity. Sometimes they don't quite extend, and there's a lot of breed variation in the position of the liver, but there's also a lot of variation in size of the liver within dogs and whatever the diseases might be as well. What about on the right-hand side of the body?
Right kidney.
Excellent. Bonus points for telling me which lobe contacts the right kidney.
And the pancreas and duodenum, pylorus.
Yeah, absolutely. So they all sit up, sort of the liver almost wraps around them. And we will, in the liver, we will also talk about the biliary tract because you can't sort of look at one without the other. So particularly the biliary system is closely associated with the pancreas and duodenum, with the bile duct running alongside the portal vein there. So they're all the structures that we want to sort of, I guess, know how to recognise to be able to know that we've looked at the whole liver. And what about the liver itself? Does anybody know the lobes and things of the liver?
Caudate.
Excellent. So that's the one.
Oh, sorry.
Yeah, the caudate one is the one that contacts the right kidney. So that's the one that I was looking for before. Excellent.
Quadrate.
Quadrate wraps around the cranial aspect of the gallbladder. So right at the kind of round part of the gallbladder. Excellent.
Right lateral, right medial, left lateral, left medial.
Excellent. Which are actually single lobes, but they've got sublobes in them. So the right side, the right lobe of the liver and the left lobe of the liver, but there's a right lateral, right medial, and left lateral, left medial. So your left medial contacts the left-hand side of the gallbladder, and your right medial contacts the right-hand side of the gallbladder, and the quadrate lobe sits up on top of the gallbladder. Excellent, Jen.
I just did a little quiz.
Jen's just said her surgical memberships. Yeah, well done. Excellent. So realistically, can you separate the lobes on ultrasound?
I don't think I've ever been able to necessarily.
It's pretty rare.
There's fluid there, you're more likely to.
Good, Jill, exactly. Yeah, so it's kind of nice sometimes when there's fluid there to do a little anatomy prac and just check yourself and check the position of the lobes, and then I guess try and extrapolate from what it looks like when there's fluid there to when there's no fluid there, and assuming that that's probably that lobe, or it's probably that lobe if you're seeing an abnormality that's focal in the lobes. So that's our landmarks and anatomy, pretty well covered. Now size. How do you judge size of a liver on ultrasound?
If it's got rounded edges, it's likely enlarged.
Excellent.
How much it sticks out beyond the, I know what to sound, on the rib cage, perhaps. Yeah, I'm not too sure, actually.
It's really hard because you can't really do anything that tells you volume using the ultrasound, and you can't judge it in context for the body size of the dog. So it's really difficult to judge size. Rounded margins are a really good tip. And the one thing I'll say about them is that you can have quite focal causes of hepatomegaly. So one lobe might be enlarged. So check a cut on the right and left liver, the points of the liver lobes. And if they come to a nice taper, probably not enlarged. If one is rounded but the other comes to a taper, you've probably got focal hepatomegaly. And if they're all rounded, then you've probably got diffuse hepatomegaly. The other thing I usually do is, so if the dog's lying on their side, I put the probe right up at just below their sternum, so the cranial-most point of the abdomen, and I point the probe directly at their spine when they're lying on their backs. And I want to see the liver entirely on the left-hand side of the screen, on the cranial aspect of the screen. I don't want to see it crossing the midline and in the kind of caudal aspect of my wedge. Does that make sense without a diagram? Probably not.
Did you say you put the probe at the sternum, like perpendicular to the dog, pointing straight up at the spine?
Exactly, yeah. And so if you can imagine, I've got, so my probe's here, and then I'm then taking a wedge.
Yeah.
And the sort of 12 o'clock on the clock is straight up. And on the left-hand side of my wedge, I want my liver. On the right-hand side of my wedge, I don't want liver, because that would mean it's extending beyond the costal arch.
So you've got the notch pointing at the dog's head?
No, notch pointing straight at the spine. Oh, sorry. Yeah, notch at the dog's head. Yeah. So with ultrasounds, what I usually do is have the notch either pointing at the dog's head or pointing at the dog's spine, or anywhere between that. I very rarely go, like my notch will never be pointing caudally. Just so on all my images, I can say that's cranial or that's dorsal. Does that make sense?
Yeah.
So so you don't get sort of confused in the images. And then if it's pointing backwards, I move the wrong way and I get all confused. So you can't really make a definitive or objective assessment of size of the liver on ultrasound, but you can be pretty sure in some cases, particularly when there's quite moderate or marked hepatomegaly. What about the echogenicity of the liver? Does everyone know the difference between echogenicity and echotexture? Or can guess?
Echogenicity is how much of a signal you get back, like the intensity of the signal, so bright versus dark.
Great, yeah.
I guess the texture's just kind of the way it looks, like whether it's all like the shape of what you're looking at.
Yeah, excellent. So it's either homogeneous heterogeneous, so mixed, or sometimes nodular in texture.
Yep.
Normal texture is smooth for particularly the liver. It shouldn't have mixed greys in it. It should all be the same grey. So what about the echogenicity of the liver? What can you do to tell whether a liver is hyperechoic or hypoechoic?
Compare it to the spleen. It should be hypoechoic to the spleen.
Good. Excellent. Sorry, Alex, can you say the first part again?
Compare the liver to the spleen, and it
Yeah.
should be hypoechoic to the spleen.
Excellent. Anything else you can compare it to?
Kidney. The cortex of the kidney.
Great. Excellent. And should it be darker or lighter?
It should be hypoechoic, darker than the
Hyper.
hyper. Oh, well.
Hyper. The liver's in the middle, remember? Spleen,
Oh, yeah.
liver, kidney. It can actually be isoechoic as well, if that's allowed. And there's another thing that you can compare it to, and in surgery, sometimes when they're desexing female dogs, they take it out, which makes it a little bit harder. What am I talking about?
The ovary.
Falciform ligament.
Good. It's not the uterus. Excellent. So the falciform fat should, oh my gosh, I'm going to need to get this right now, should be hyperechoic in dogs and cats to the liver. In obese cats, the liver is often hyperechoic to the falciform fat. So the echogenicity of the fat varies on how much fat there is, obviously. So that relativity, we lose that a little bit, the relativity in that. So I usually get a picture of the spleen, picture of the liver, put them side by side with the same gain and settings on, and just see which one's darker, basically, to assess the echogenicity of my liver. All right, so that's the things we're going to think about when we're looking at images. We're going to think about the landmarks, the anatomy, the size, echogenicity, and echotexture. They're the three things I want you to try and comment on if you can. So just a quick review of how I actually make sure that I've looked at the whole liver. I essentially start with my probe right in the middle, up at the sternum, and I look dorsally up through the liver, and I've got my probe craniocaudally in orientation. So I've kind of got a wedge right through the middle of the liver. And then I fan it right out to the left until I can see this tip of the left liver lobe there. And I keep the diaphragm in the whole time, this bright white line of the diaphragm, so that I know that I've assessed the cranial-most aspect of the liver. And then I fan back to centre, check the gallbladder, and then I fan right out to the right to check the right side of the liver, and again keeping the diaphragm in the whole time. Then a lot of the time you can't, if you get the diaphragm in your view the whole time, you've only assessed the cranial-most aspect of the liver. So if there's liver that I haven't assessed, then I will move my probe caudally. So I will tilt rather than slide the probe, and then I'll do the same movement. So I'll go right to left further caudally, and keeping the caudal-most aspects of the liver lobe tips in my view. Does anybody have any other different techniques that they use?
Can I just ask, on that right-hand pit diagram there, you've now rotated your probe by 90 degrees, haven't you?
I don't actually. I often do if I'm looking at vessels and things, like if I'm looking at a focal point in the liver. But this, I don't know if they haven't marked craniocaudal there.
Because you can see the shadows. Can you see the shadows?
Oh, I see. Yeah.
And
Well, that's a really clever thing to do.
Yeah. The reason I asked that was because, you talked before about the fact that if you had anything, you wanted your liver all off to the left, and if you had anything to the right, then you knew that the liver was enlarged.
Yeah.
I'm still struggling with that a little bit.
Oh, right. Okay, sure.
Because in this
Okay.
view, yeah,
So on this view, that's not going to tell you how much of the liver is cranial, how much is caudal. It's going to tell you how much is right and left, right?
Yes.
Whereas on this one, so that's the view I do to
okay,
check how much liver is on cranial or caudal. And if my probe's right there,
yeah,
pretty much all the liver is up there, and there
Yeah.
shouldn't really be any liver on this side.
okay,
This
Yep, no,
liver in this diagram is extending well beyond the costal arch. See that?
yeah,
So in this example, you definitely see liver on the right-hand side of your screen. You could probably say the liver extends beyond the costal margin.
yeah, okay.
That's a better demonstration than my triangle hands.
It's just it's a hard concept, but I get it now. Yeah.
Well, it's a hard concept when I haven't given you the orientation of the patient, for sure. Excellent. Okay. So, and then you can see the sort of, when you're looking at the left-hand side of the liver, you're going to have the body of the stomach up there, a little bit of duodenum when you head to sort of the midline, and we'll see some of the architecture and landmarks in the images that we go through. So when we're talking about size, echogenicity, and then if there are any focal lesions, how we're going to describe them. So the echogenicity changes with the liver. They can be diffusely hyperechoic, diffusely hypoechoic, or diffusely mixed in echogenicity. And some people call that heterogeneous. With size changes, you can have generalized hepatomegaly, focal hepatomegaly, or microhepatica. And with focal lesions, they can be anechoic, hypoechoic, hyperechoic, or of mixed echogenicity. So I want you to just think about those, or try and use those terms as we're describing if you can. And now we'll go on to images. So this is a 10-year-old male neutered schnauzer who presented with an incidental finding of elevated liver enzymes. Does anybody want to have a crack at giving me some descriptions of this liver?
Well, the echogenicity and the echo texture are both mixed.
Mm-hmm.
There's the gallbladder is quite large. The wall looks okay, but the liver capsule is more hyperechoic than usual.
Are you thinking this distal part of the image?
Yes, yeah.
Good, okay.
And no, I wouldn't call it nodular necessarily, but yeah, very mixed echogenicity.
Good, excellent. What do you think about the margins of the liver? Can you see a tip of a lobe? What do you think about that shape?
It's rounded.
I agree. So if we think about the things that we're kind of looking at, size, we have some soft evidence of increased liver size with rounded liver margins, but without the context of the rest of the liver. You can't really comment on size. With echogenicity, I agree that it's mixed, absolutely, and I agree it's probably generally a little bit hyperechoic, but we don't have the relative spleen or fat or renal cortex to say that definitively in this image. And the gallbladder, how do we assess the gallbladder? We didn't talk really about that. What things are you going to want to notice in the gallbladder?
Wall thickness.
Good.
Presence of sludge.
Yep.
Also presence of a mucocele.
Yep.
Distension. And the ducts leading from it, are they distended or not?
Good. What shape should the gallbladder be?
Probably a pear shape rather than a ball.
Good, excellent. Yeah. So pear-shaped or teardrop shaped. What factors might influence gallbladder size?
Sedation?
I don't know, actually, Jen. Do you know?
Not for sure, but
Sorry.
I think I've just like assumed that that might affect it in the past. I don't know if that's right or not though.
Is your impression that sedation decreases the size or increases the size?
I increases maybe because like don't you get a bigger gallbladder if you've got ileus? Like if you
potentially, and that's actually, I think a lot of the patients that we sedate have been fasted.
Yeah.
And that's what I'm getting at. Is
all right.
it's actually food passing from the stomach into the duodenum, which triggers the gallbladder contraction via, does anyone know the hormone? I'm testing you now.
Is it cholecystokinin?
Who said that?
I was going to guess that.
It just randomly popped into my head, but I don't know. I don't even know what that is.
It is. That's exactly what it is. So when meal passes into the duodenum, it triggers gallbladder contraction to help with fat emulsification. So that the bile obviously breaks down the fats in the diet into a form where the lipase can then break them down further through its detergent effects. So anorexia causes the gallbladder to be quite rounded and full often, and we usually do ultrasounds on fasted patients. So quite often we're looking at the gallbladder going, is it obstructed or is it just full? And the thing that really helps us to differentiate that is the shape of the gallbladder. So an obstructed gallbladder is quite round, whereas a normal full gallbladder maintains its teardrop or pear shape. But all the other things Jeff mentioned with wall thickness and things like that are all perfect. They're exactly the things that I look for. Now, something else that was mentioned in the kind of review of this image is that the liver capsule was bright. Now, I actually think this is the diaphragm, if that's what we were referring to. Because I can't see the same bright capsule around this side, I think that's actually the falciform fat. But again, we don't have enough context in this image to judge it. For kind of when we're just sort of practicing assessing images, obviously. But just for context, this is a dog with Cushing's disease and probably hyperlipidemia as being a schnauzer as well. So the liver was quite bright. And the other thing that it's very subtle, but there's actually just a really subtle thickening of the gallbladder wall there as well, which we do sometimes get with hyperlipidemias. All right, let's move on to the next image. I've obviously labelled some stuff in here that might be noteworthy.
Yeah, well, mixed echogenicity and texture.
Yeah.
And there's, yeah, it's hard to say whether that's the gallbladder or not. Also, there's fluid there on the upper right of the image.
Good.
And just to the right of the fluid, I'm not sure what that is. If that's liver, it's not very happy.
No, that's fat.
Yeah, that makes more sense.
Mm. So this is a picture of the left liver lobe. The structure in there is definitely not gallbladder. So this is a situation where we're not just describing the liver. So we've talked about the echo texture and echogenicity of this liver. We can't really comment on size. Now let's talk about how we define nodular lesions within the liver. So does anyone want to have a crack at describing this structure?
You could say it's pretty well circumscribed.
Mm-hmm.
It's not extending beyond the boundary of the liver, so it's not distorting the wall of the liver.
Yep.
It's of mixed echogenicity.
Mhm.
Certainly looks like there's fluid inside. It looks like there's a thick wall.
Good. Excellent.
What else can I say? It doesn't look like there's vascular structures in there.
I agree with all of those statements. Given that, what would your list of differentials be for this lesion?
I put cyst at the top. Yeah. Well, if you hadn't written cyst there, I don't think that would have been the top. I would have thought of some mass in the liver that's obviously got fluid inside it. So yeah, cyst, it could be an abscess. It could be a neoplastic lesion with a necrotic center.
Yeah.
It's unlikely to be a hematoma. Oh, I guess it could be, but it's got a thick wall for a hematoma.
What about a hematoma in a mass?
Yeah. Could be a, I was just thinking of hydatids. I've never seen a hydatid cyst, but I guess that's a differential for a cyst more than mass.
You won't see a hydatid cyst in a dog. Dogs have the tapeworm.
Not the cyst, yeah.
They're a primary host.
Yeah.
Good point.
Caught me out, yeah. That shows how,
well, I
was going to say, that shows how often I've dealt with hydatids, full stop.
Exactly.
That used to be a trick question for the students.
I'm going to stop putting that on my differential list when I do ultrasounds. So Jill, I think you raised some really interesting points. So I kind of threw you guys a curveball by writing cyst in this structure. And in theory, that's correct because it's got fluid in it and it's a thick-walled, fluid-filled structure. But a cyst is not, a sort of degenerative cyst is not high on my list of differentials for this, given how echogenic or mixed in echogenicity the material in the inside of the that cystic structure is. So I agree with you, Jill, that abscess or neoplasia with a necrotic center or an organizing hematoma would be the highest things on my list for this lesion. Hematomas are interesting because when they bleed, they're obviously liquid. So initially, if you see them very acutely, they're black. And then as the fibrin comes out of them, they get quite echogenic. So not quite as bright as this here. But then when they start to actually organize, they're certainly this bright, and there's often, we call it a target lesion. So this bright center and then this very dark surround. And that's really pathognomonic for bleeding, particularly sort of nodules that have that target appearance to them, is quite consistent with a hemangiosarcoma, not pathognomonic for a hemangiosarcoma, but quite consistent with a tumour that is prone to bleeding. It's a very good description, Jill. Okay, so in this image, we can see the probably left medial liver up here, portal vein coming in here, and then adjacent to the portal vein, a hepatic lymph node, which should be around 5 millimeters in diameter. And next to the hepatic lymph node is the fat at the hilus of the liver. Can anyone comment on this image?
I can have a go.
Yeah.
Looking at the liver, I suppose it's kind of hard to comment again exactly on its echogenicity, but it's hypoechoic to the fat surrounding fat, or the fat is hyperechoic to the liver.
Good.
The liver itself, I think this is where it kind of gets hard with still images, but it does look like it has mixed echogenicity there, but it could, yeah, it's hard to kind of, I think, comment.
I agree.
There looks like there is free fluid between the liver lobes as well, just be distal to the portal vein. And that hepatic lymph node does seem to be enlarged.
enlarged in size, or is there anything else you're looking at that's making you think that that might be an active looking lymph node?
How plump it is and how it's surrounded by hyperechoic fat. So it's quite rounded compared to what it would normally look like. And it's 7 millimeters wide, which is kind of on the, well, just above like what would be normal, I would say. And also that's kind of width as well. So it's quite, yeah.
It's also got erratic borders. It's not a smooth border.
Yeah, absolutely.
The lymph node or the liver?
The lymph node.
Yeah.
I think you'd probably be accurate saying that about the liver as well, actually.
Yeah, and I think the liver looks kind of small, but it's, again, not sure.
Yeah, and I think we're probably looking at just a little window of the liver, like, you know, when you're pushing up to capture the hepatic lymph node, you kind of squash the liver out of the way as well. So I don't know if we can judge size on that.
Because my initial gut feel with the liver was, I would say it's hyperechoic is my gut feel of the liver. But
it was actually really.
But I have nothing to compare it against. So.
Yeah. So all of your descriptions were perfectly accurate. And what I want, like, I don't want you guys to feel bad about saying I can't comment on this, I can't comment on this, because that's then when you're actually doing the ultrasound, they're the things you'll be looking for. What do you think about the vasculature throughout the parenchyma of the liver, other than the main portal vein I've pointed out?
You know, like the portal vessels.
Yeah.
They're quite, I mean, the borders are quite hyperechoic, but that's normal.
Good. Excellent. What about this one? What do you think that is?
Portal vein, I'd say. Just doesn't have the hyperechoic borders.
Did you say portal vein?
Portal.
Hepatic vein.
Hepatic vein, yeah.
Hepatic vein, sorry. Yeah, it's
yeah. So I think this is a really important differentiation. Josh, I've told you before. Do you want to tell everybody the difference between how to identify portal vasculature versus hepatic venous vessels within the liver?
How to remember it?
Beg your pardon?
How to remember it?
Yeah.
So the way to remember it is that the the portal vessels are draining from the gastrointestinal system and the abdomen. So all the kind of gross stuff that comes from the gut are kind of being drained through there. So you'd think that the walls would be hyperechoic, even though that's potentially not actually a true medical thing. It's just a good way to remember it.
Sorry, I didn't mean my made up story about how to remember it. I meant just that the portal vessels are bright, but the hepatic vein walls aren't. So you can tell the difference between them.
Yeah, that's how I remember it.
Yeah.
It's as bad as having children catching you out, isn't it?
It really is. But it does, that is exactly how I remember it. So the portal veins have got all the toxins and stuff from the intestinal tract. So they need to have thick walls to protect the liver from it, which is so untrue, because obviously the liver's job is to filter all of those out, and it wants to see it, all those toxins. But the good thing, the nice thing in this image is that we've got a hepatic vessel or hepatic vein here and a portal vein here, which are quite similar in size. And they really should be, like, if they're sort of right next door to each other, the hepatic vein and the portal vessel should be pretty similar. So if you've got any change in portal vasculature, like a shunt or something like that, you're going to have decreased flow in the portal vessels, and they'll be smaller than the hepatic veins. And if you've got congestion, like right-sided congestive heart failure or something like that, the hepatic veins will be congested and they'll be bigger than the portal vessels. So it's A, good to be able to recognise which vessel's which, but B, to look at them kind of, if you happen to see them both in the same image, to be able to say, okay, those are equivalent in size, and therefore there's probably not either a congestive or a shunting problem going on. All right. So moving on to this dog, this is a really poor image. This is the liver margin here. And within that liver, there's this hyperechoic lesion, which I've just described for you. Can somebody describe it any further?
It's focal.
Focal, good, excellent.
with an irregular border.
Very good.
There's also fluid between the liver and the diaphragm.
Do you know what? I actually think that's a duodenum with gas
Oh, is
in
it?
it. Yeah, sorry. It's all
I was
about
going to say that. I was going to say that too, as in the fluid.
fluid. Yeah.
Yeah.
Sorry, guys. If you were doing it, you'd know that I was looking the other way, not the diaphragm.
So the orientation's different from the one that I didn't realise was the diaphragm. I thought the diaphragm was on the other side, but
Yeah.
it obviously is now.
Agree.
So the liver parenchyma is a mixed echogenicity. Because there's hypoechoic scattered focal areas through it. And just on the near view, there's some hyperechoic nodules. And the mass has hyperechoic nodules in it as well.
Mm-hmm. What are the differentials for a hyperechoic nodular lesion in the liver?
I'd be thinking things like infiltrative or increased cellularity, is creating them to be more dense. That's why we're getting those kind of echoes.
Yeah.
So things like inflammation, or hemorrhage, or neoplastic cells. Jess also just mentioned that things like fat can also increase echogenicity.
Good. So
this scenario seems like it's kind of crossing portal vessels as well. It's kind of it's kind of smudging through everything. So I'd be
smudging
thinking,
through, but
sorry, that's not a real term, but
I know what you mean. Is it distorting though? Those vessels?
No. Well, I can't comment on the one to the left, but the one on the right, it seems to be kind of fading out. I don't know how to describe that.
Yeah.
But it doesn't seem to be compressing it, I would say, or anything like that. On the right.
I agree. Yeah. It doesn't look like it's a kind of space occupying lesion. It just kind of looks like it's in the normal liver structure.
Yeah. So things like inflammation is something I'm thinking of.
Okay. If you had just nodular hyperplasia, would you see the vessels sort of attenuate like that? Or if it was had nodular hyperplasia, would you still just get the vessels traveling through it?
Do you know what? Nodular hyperplasia is on the list of every single possible appearance of a nodular lesion in the liver.
Okay.
So yes.
And no.
Yeah. So always have it on the list. If you're, particularly the people sitting membership exams and stuff, nodular hyperplasia is on the list no matter what it looks like. Except anechoic. Nodular hyperplasia is never anechoic.
Okay.
So neoplasia wise, are there any particular sort of neoplasias that you would be more suspicious of, like benign versus malignant, or are there, like, if you had to write top 3 possible differentials for a neoplastic cause of this lesion, what would it be?
Oh, probably like round cell neoplasias would be one thing I'd be kind of leaning towards.
Yep.
So, I mean, the benign versus malignant would be kind of tricky, I think, without kind of knowing the rest of the scan. But the things like lymphoma, mast cell disease, or like histiocytic disease would be kind of 3 that I'd be thinking of on the more malignant side.
Yeah. And what about benign? We've talked about nodular hyperplasia. Are there any other hyperechoic nodular lesions in the liver which are benign but neoplastic still?
Like carcinomas or?
Benign though?
Mangiomas?
Yeah, good.
Oh, yeah, that's a good one.
There are commonly nodular hyperplasia that's harmless.
Yeah.
Like lipomas? lipomas, but it doesn't seem as well demarcated as
No, it's got a
Yeah.
rough edge.
to be.
Agree. So you kind of mentioned it in your sort of commenting the deposition of fat, myelolipomas, they're called, that tend to be quite bright and poorly demarcated and just in the parenchyma without distorting things. So that's one that I'd put on my list for this.
So I was just going to ask, do you think that the rest of the liver looks mixed echogenicity? Because I guess that would draw you away from thinking this was a benign lesion. That's all I was saying.
I actually thought this liver was quite smooth in echo texture, but I don't think I've got enough of it in this image to make that. I wouldn't call it that on the basis of this image, but knowing this patient, I thought the rest of the liver was normal in size, quite smooth in echo texture, and it was actually normal echogenicity, but then it just had this bright lesion in it.
Okay.
There are about 4 that I can see on the right there of hyperechoic, like cystic type structures, and your cross D1 or B1
Down
is
here,
it?
yeah.
It's in one of them.
I agree. It looks like that on this image.
Yeah.
But just the liver as a whole, like this region is obviously abnormal, but the rest of the liver was quite homogeneous.
Okay.
But it doesn't matter. This is as far as the differentials for nodular liver change. The fact that it's an isolated lesion, I think, changes your differentials a little bit. But for the purpose of the discussion, I think it's interesting just to look at the different causes of hyperechoic nodules specifically. The other one that I will put on my list is hepatocellular carcinoma and hepatoma, which are both tumours that tend to be hyperechoic. And usually most of the differentials we've talked about will be diagnosed on fine needle aspirate, or at least we'll be able to say low grade, high grade, and know whether we need more information about it. So in a lesion like this in the liver, I usually recommend aspiration and cytology. Okay, so moving on to the gallbladder. This is a picture of liver here, gallbladder here. Can anyone make any comments on the gallbladder? Actually quite a grainy image.
Has some dependent, well, I think it's dependent sludge,
Good.
echogenic sludge.
Excellent. Normal or abnormal in a dog?
Probably a normal amount if it seems freely moving.
Good.
I think.
Excellent. So gallbladder sludge in dogs is a variant of normal. So where we call it abnormal is if it's hyperechoic or if it's mineralized and we see a shadow underneath it, or if there's changes to the gallbladder wall accompanying it, in which case we think, okay, maybe there's more of an inflammatory component to it. What about the liver echo texture that you can see here? Smooth or?
Yes, it seems homogeneous, I would say.
I think so too, yeah. Good. What about this gallbladder?
The wall looks hyperechoic
Good.
Layered.
Good double wall.
and thickened.
Yeah, I agree. Yeah,
It's layered as well.
it is. Yeah. What does that mean?
Dog's got heart disease.
It's one of the differentials, Jill.
What's the
It's got edema of the gallbladder wall.
Good. Excellent. So when you see that double layer, the halo sign, it means that there's fluid in the gallbladder wall. So what are the differentials for gallbladder wall edema?
Anaphylaxis.
It's such an emergency bed, Helen.
Pericardial effusion.
Good.
Right-sided heart failure.
Good.
Another one that's really a bit bizarre, isn't it?
I missed that one, the adhesion one. What was that?
Oh,
Some-
anaphylaxis?
Yeah, I got that, but something adhesion.
Effusion.
Pericardial effusion.
Oh, effusion.
Yeah.
Would portal hypertension do that as well? Or like just anything that can cause congestion within the liver? Or is it more just higher up, like caudal vena cava congestion?
It's higher up. So portal will affect from the where the portal vein enters the liver down to the gut, spleen, pancreas, whereas caval or heart congestion will cause congestion in the liver and gallbladder itself.
Cool.
So there's one more big differential for gallbladder wall edema.
Like hematoma or
Ooh,
trauma?
it's a good one. It's not the one I was thinking of. I don't know if it
Came up at the trivia night. I can't remember what it is.
Colangeitis?
No, done.
good. Yay, Jet.
What was it?
Colangeitis.
Ah,
So if you think about, go back to your Dammit differential, like forming differentials, if you've got edema somewhere, inflammation has to be on the list. So local inflammation, as well as obviously congestion or vascular in this case. So local inflammation, most common cause of that is bacterial cholangiohepatitis. And we certainly see gallbladder wall edema or changes like this, particularly where you see that gallbladder wall, and this might just be an artifact, but it looks a little bit irregular there as well. If there's other signs of kind of active inflammation in the gallbladder, like a little bit of free fluid at the neck of the gallbladder, or a little bit of hyperechoic or mineralized sludge in the gallbladder, that would add weight to a local inflammatory process rather than anaphylaxis or pericardial effusion as a cause of these changes. All right, how ugly is this liver?
Whoa.
Whoa. Okay, who wants to comment on it?
Well, if that's the gallbladder, hang on, it's portal vein. Okay, portal vein.
Yeah.
It looks like you've got a lot of varying echo texture within the liver. It looks like you've got fluid up the top, because I'm assuming that can't be a vascular area up there.
Right.
I think you've got fluid. Now I'm going to assume this is the diaphragm down the bottom. So I think you've got fluid down there as well.
It is, yeah.
The portal vein looks huge.
I agree. Should be less than 5 millimeters in a cat.
Okay.
This is a cat. Sorry.
Right.
Important information.
Yeah. Okay. So the vasculature, if some of those other areas are vessels as well, it looks like a lot of engorged vasculature.
Agree. Yeah. So we've got congestion in the portal vein outside the liver. And then what do you think of, so these are actually end-on vessels.
So they'd be hepatic veins.
I think they're hepatic veins as well. They don't have the bright walls that the portal veins have. So if we've got hepatic venous congestion and free fluid and portal venous congestion, what sort of pathology would we be thinking of? Where would we localize the problem to?
Something causing pressure on the vena cava.
Good, excellent. So I think it has to be cranial cava or higher. So either heart or cranial caval disease.
Yeah.
Excellent. This cat's having a CT today.
Okay.
Yeah, that could be, if it's it could be pericardial effusion.
Yeah, absolutely.
Heartworm.
Yeah.
Infiltrating tumor in the cardiac wall.
Yeah.
Maybe hypertrophic cardiomyopathy.
Potentially, yeah. No pleural effusion though.
What else have I got? mentioned heartworm. That's less common in cats. Yeah, I'm exhausted for ideas there.
You've done well. So I think the only other thing would be potentially neoplasia, which is causing extraluminal pressure on the caudal cava, or neoplasia of the caudal cava itself. So we've sort of talked about the heart, but not so much the actual cava, but it's so rare. But it's called Budd-Chiari syndrome when it's the cava or the right atrium.
Yeah, like a precardiac mediastinal mass, cranial mediastinal mass.
Yeah, potentially. That would have to be pushing directly on the right atrium to cause just congestion in the caudal abdomen.
Yeah, I'm getting confused here. It causes lymphangiectasia, that one.
Yeah, yes, exactly. And you usually get a chylothorax in that situation. But yeah, something that's impacting the caudal cava anywhere between the right, where it attaches to the right atrium, it empties into there, back to where it goes through the diaphragm, through the liver.
Yeah.
All right. I feel like we might just be sticking with liver today rather than doing the spleen. Let me just see. Okay, let's go on to a biliary one.
Whoa.
This is an image of a cat who's neutrophilic, pyrexic, anorexic, and has an elevated ALP and ALT and total bilirubin. This is a picture of his common bile duct. Does anyone want to comment on that?
Wow.
Yes, agree.
It looks looks tortuous.
Good.
As well as it is distended as well.
Mm-hmm.
It contains anechoic fluid, and the walls are hyperechoic.
Excellent.
I can't see any kind of mineralization in that view.
You can't, sorry, say again?
See any mineralization within the lumen in that view.
No, me neither. What else about the walls? They're hyperechoic. Are they otherwise normal?
They appear thickened.
I agree.
And it looks like the surrounding parenchyma is also, or tissue is also slightly hyperechoic as well. I'm not sure if that's artifact because it's kind of just distal to it from the probe.
Yeah.
Or if that's true. But.
Yeah. I agree with all of those statements, and that's pretty much exactly how I would describe this in an ultrasound report. So looking at the measurement, what do you think about, so you've said it's dilated or distended, which is true. Do you know anything about the sort of cutoffs measurement wise for obstructed versus cholangitis?
5 millimeters is the cutoff I keep hearing, but I'm assuming it can be, that's pretty close, so that's possible.
And
it's obstructed.
It's probably going to be a spectrum as well. So when it's first obstructed, it's not going to be 5 millimeters. And inflammation is going to cause a degree of partial obstruction, particularly if there's inflammation right down at the duodenal papilla. It's just bile's not going to flow through there as well. So you're right that 5 millimeters is technically the cutoff for like a marker for obstructive pathology. But this cat's getting up there, and you can see that the loop of common bile duct that's been measured is not actually the widest loop. So say if we'd measured up here, this cat would probably be classified as having an obstructed bile duct. So this is a cat with, what's the leading differential with the history that I've given you and these ultrasound changes?
So things like extrahepatic bile duct obstructions.
Mm-hmm.
So that can be things like docyliths or neoplasia or pancreatitis or duodenal obstruction, foreign bodies, those kind of things.
Good. Very good differential.
if you sort of had cholangitis, hepatitis, you know, when the liver gets so thickened, would you see them as dilated as that? Because they do seem huge.
Yeah, absolutely. So I actually think probably one of the most common causes of this degree of dilation, this diffuse wall thickening and change, is probably inflammatory rather than extraluminal obstruction. In a dog, I'd say extraluminal obstruction more common, but in a cat, I would say ascending bacterial cholangitis is the most common.
I don't know whether
cause
you
of
can
the
hear me,
change.
but I've lost you.
Oh, I can hear you. Is
Yeah, now that you're back again.
that better? Okay.
Can you just say that once more? You said the
Yeah.
most common thing, and then I lost the next 20 seconds.
Yeah, so in dogs, I would say the most common cause of these sorts of changes would be pancreatitis with secondary extrahepatic biliary obstruction. In
Okay.
cats, I'd say the most common cause is actually ascending bacterial cholangitis, particularly when they present septic looking, so with a neutrophilia and with elevated bilirubin and pyrexia. I would say bacterial infection would be my number one for this cat,
Right.
particularly if we then ultrasounded and we can rule out chololith in the distal bile duct, pancreatitis and duodenal obstruction. You know, it's nice to be able to say that that's not what they are.
Yeah.
So ultrasound would help to clarify all those things. All right, so we got through liver and gallbladder. Tell me, I know it's frustrating doing stills. Was that beneficial, or is there a format you'd prefer we used when we do these in future?
I thought that was really good.
Yeah,
Yeah,
it
that's
Me
awesome.
too.
worked well.
Okay.
Worked well.
It was
Alright.
really good as well, Anna, how at the beginning you kind of set the kind of structure of how we're meant to kind of describe it, so it gets that in our mind as we kind of
Yeah.
work through it.
It's
I
good.
agree. That was good.
Particularly those of you doing oral exams, it's really good to just have, I need to comment on size, anatomy, landmarks, echogenicity, echotexture. And you'll get all the marks if you cover that checklist.
Cool. Thanks so much, Anna.
Super.
Yep.
See you guys.
Okay.
That was great. Thanks,
Bye.
Anna.
Bye.
Thanks a lot, Anna.
No worries. Bye.
Bye.